excited to introduce Chris Magdalinkis, gosh, I gotta practice that, and Jason Buell from Valley Health Hospitals. Chris is part of the informatics team at the Valley Health System, focusing on alarm management. With the construction of a brand new 400-bed smart hospital, Chris led the efforts integrating various technologies to support and advance clinical operations, patient safety, and experience. Jason is the IT project manager and applications developer for Valley Health System in Paramus, New Jersey. He is responsible for assuring strong, oh, we got a New Jersey fan? Yeah, I think I heard a New Jersey fan for you. Strong cooperation to ensure successful implementation. Previous clients include CDC and La Jolla Institute for Allergy and Immunization. He's also certified PMP with experience extending to full stack developer and Agile Scrum Master. We are excited to welcome you as our first presenter this morning.
Thank you, Jane, for those introductions. A little daunting to be up here today. The speakers that we've had so far have set the bar very high. So Jason and I are hoping to continue that momentum as we share with you how Valley established a single source of truth using Connexall Unit Whiteboard for our staff assignment system. Jan yesterday basically said, how does a nurse become a technologist? So I'm going to one-up her question and rebut that with, how does a technologist become a nurse? So prior to nursing, I spent over a decade in the IT space, went back to school and went bedside as a clinical nurse in the ED. And while working as a nurse, realized there's a couple things that keep kind of itching and irking me about how we do things and how we deliver care and how we use technology. So like many of you here in the room, the question really said, how do I improve this? And it was just kind of a natural ability for me to kind of dovetail that technology experience and the ability of being a nurse to say, this role of an informatics nurse specialist at Valley really makes sense. How can we use technology to better improve patient care and really better improve the clinical experience?
I'm an IT project manager. I originally started as a developer, a full stack developer, and just kind of grew in the ranks and eventually got my PMP and also a Scrum Master to lead project teams. My previous work before Valley was with the CDC and also with the La Jolla Institute of Allergy and Immunology in San Diego, California.
So a little bit about Valley Health System. So Valley Health System is a single hospital facility and a health network that we have. We are located in northern New Jersey. We're just outside of New York City. And we're one of the few hospitals that still has remained as an independent single facility and not been absorbed into a larger system. We have our patient population is from the northern New Jersey area as well as southern New York State. But a big competition with those big networks really means that Valley has to kind of punch above its weight. So we've historically done that by always providing high quality care, often high touch, and more increasingly high tech. The hospital kind of sits on a stool with three legs. We have our hospital itself. We also have a home care agency and the Valley Medical Group network of our providers and specialists. The reason why we're up here right now is because in April of this year, Valley opened a brand new 900,000 square foot state-of-the-art hospital. So we moved 2 towns over and really kind of built this from the ground up. Slides are actually a little dated here. So when it was put together, it said 370 private inpatient rooms. Last look, we're actually at 416. We have an exploding census right now, and we've really kind of had to hustle and flex and turn spaces into additional inpatient rooms to kind of handle that census and the capacity that we have going through. So with opening a new hospital, one of the challenges that we had was we wanted to take a look at our work streams that we had in our existing hospital, so our Ridgewood facility, and saying, what works, what doesn't, and how is this going to change as we move to the new facility? And part of this project was really taking a look at staff assignment and the burden it was creating for our staff. We started seeing that as we kept leveraging and putting newer technology in and integrating more and more technologies, clinical operations just basically was hand in hand with technology. And we started having multiple applications across multiple devices. So no longer was it just the nurse logging in the EMR on their computer, but now they've got a mobile device that they're logging into, and we keep expanding this sort of ecosystem. And what that made was challenges with usability. So like all the hospital systems here, we always have issues with retention, with bringing new nurses on. We just became an academic medical center, so now we've got residents added to the mix. So when we bring these new employees on, we want to be able to have them have systems that are intuitive and easy to use. So having that complexity really starts becoming a challenge. And the hospital itself was a challenge. So we created this brand new facility, and leadership and administration decided we're going to go with a big bang approach. We are going to, in one day, shut down the old hospital, bring up the new hospital, move hundreds of patients over, all at once. But I know we had conversations last night at the dinner table talking about poker. My executives must have been there because they wanted to go all in. So in addition to this new physical facility, virtually every technology and platform was decided to be changed at the same time. So we're now moving into a new building with all new technologies. Historically, there was an issue of culture within Valley. So because we were a single entity hospital, a lot of times projects were done by the clinical leadership saying, here's our need, and how do we work with our analysts and our specialists in order to find the best application that fits our need. And these were kind of done as projects in silos, and based on various areas, we had silos where they didn't talk as well as they should have. So maybe we had competing technologies, and there was definitely areas where there was not a holistic look of how do these technologies play well together and how do they integrate. So it really fell on Valley to have our IS services kind of have to build glue to make a lot of these disparate best-of-breed systems communicate and talk and kind of maintain that system. So really it was a diverse selection of technology rather than having an ecosystem that was more turnkey. And I said we did change a lot of the technology out, but what we did keep as our legacy systems that were core to us, we kept our EMR and our communication platform. And we are probably one of the few shops in here that doesn't use Epic. So with Meditech that we were using, we still inherently had some legacies and some limitations that were there. And likewise with the patient touch solution that became Vocera Edge, some hurdles that we had when we wanted to take a look at integration. So new hospital, new technologies, new workflow requirements, really wanted to take a look at how do we fix staff assignment. And we wanted to do so by establishing a single source of truth that would flow downstream to all of these systems that were requiring their own data. We wanted to evaluate the capabilities of the core components we had, because if our current systems could do it, well then why do we need to buy something new? And I think it's probably no spoiler here that it couldn't, hence why we're working with Connexall to be a key partner to kind of fill some of those gaps. We wanted to basically kind of develop that cohesive ecosystem, integrating these disparate systems. And we wanted to basically create a system that was going to be friendly. And that's a real principle throughout this entire era, is keeping it simple so that it's just usable for the nurses, and that usability was a key impact. But we wanted to measure things. So we wanted to measure the impact on operations, efficiency, and satisfaction from both staff and patient. So formal abstract slide, but really what we're up here for is we want to share the learnings of this process that we went through, right? It wasn't perfect, but there was a lot of stuff we learned, and we're hoping that maybe it's something that you guys take back on your next build and your next implementation and said, hey, maybe this unit whiteboard can do some stuff for us as well. I really like this slide, not just because I put it together, but it's a really simple way of showing how things were increasing. So to the left of the green line, what you see is the EMR, so we had our nurses logging in on computers for it, and the communications platform. To the right of the green line were all of these new systems that we're starting to put in place in the new hospital. We're adding physiologic alerts and alarms that are now routing to devices. We have AI fall prevention and corresponding apps that go along with that. The nurse call system, patient digital whiteboards within the rooms, and unit whiteboards at the nursing care stations. This is just a selected amount. It keeps going. And now anybody here who has actually used mobile devices may know these beam cases. These cases are bomb-proof, but they have a very thick plastic screen guard so that you can use that purple top wipe on the device. Anybody who's got big thumbs, thick screen protector, it's not a fun experience to be able to do it. So we were asking our staff to have this distributed model where all of our clinical staff at the beginning of the shift are assigned a phone, and they were going on to Vocera and going through multiple screens for each patient in order to be able to make those assignments. So just an uncomfortable process. And so when we say that everyone has a phone, we mean everybody. We have our primary nurses, buddy nurses, PCAs. We're very much into using these mobile devices. And all of that distributed model and the ability to having to use a device and to do all these assignments really was taking its toll on efficiency and accuracy. So we wanted to measure, and we went upstairs and we did pre-assessments of how much time does an employee spend during their shift to make these assignments. And what we kind of came about was that it takes about 15 minutes to make these assignments, both in the beginning of the shift when you have to hand over your assignment for a break or lunch, as you have new admissions coming up. It's a continuous process and it starts eating into the time of the day. So simple math up here, and we say, well, on average of 10 employees on a unit and 2 shifts per that unit, we're talking about 5 hours per unit of time spent on the administrative task of doing these staff assignments. And if we multiply it out by the hospital, we see that's 75 hours a day. So we had efficiency that we could gain from improving this. We also took a look at accuracy. So when we audited it, we realized that while using this distributed model, it only works when everybody participates and everybody does what they're supposed to. So what we saw was that about 75% of the assignments were correct. So we had issues there where you had an incorrect assignment. And a quick example of this is we tried to use rules within Vocera for exclusivity so that we would have a new nurse signing and would bump an old nurse out because we knew the nurses weren't logging out. But if that was a case where I was a physician and I took a look at that care team and said, who's the nurse taking care of it? Well, it's Nurse Sarah. I try to reach Nurse Sarah and I don't get her. Well, Sarah left yesterday at 7 p.m., but the person after her didn't make those assignments. The whole system kind of falls apart and it impacts communications. And the other thing was staff satisfaction. Because we started adding to the complexity of our overall system, the staff started seeing technology as a barrier, as a hurdle, rather than as something that was helping them out. And we really kind of wanted to combat that and say, no. At the end of the day, this technology needs to improve the clinician experience so that you can do what you're meant to do and provide care. Staff balancing of the clinical care versus operational tasks. So for my nurses in the room over here, we always sit there and say, we want to practice at the highest extent of our licensure. And that's really providing that expertise and that patient care, right? It's not doing administrative tasks. So how do we are able to pull those nurses back, give them that time so they can do those high-skilled tasks? And then we, again, because it was a distributed platform, we had inconsistency with the results. The last topic up here is that changing dynamic of communication. And it's something that I wanted to highlight was that with these younger nurses coming in, we have a generation that grew up with their cell phone in their hand. They are so used to this notion of sending digital messaging, seeing read receipts, and being able to respond back in a timely manner. We're seeing a lot less of the face-to-face communications at the nurse's station, or even some of these phone calls. So we really wanted to make sure we had our messaging system down pat. So how do we start the project? So really, one of the big things that Valley did from the get-go was that we had this institutionalized dyad. So Jason and I worked together, attached it to the hip throughout this project, with nursing informatics representing the clinical ask and needs, and IS representing the technical capabilities. So rather than having to have formalized meetings, we were in constant communication. He was part of my work, I was part of his. And we really were able to get that transparency and clarity of the clinical ask into the product when we went into building it. And so as part of that, nursing informatics had our interviews, we had our focus groups, we started putting things together. And one of those things that I like to highlight out of here is, for any of the nurses in here, you probably use the PDSA or PDCA models of plan, do, study, act. Well, for the tech guys in here, right, it's the SDLC. How do we actually have a development life cycle? Well, you can superimpose the two. At the end of the day, it's just good practice of how do we plan, how do we design, analyze, how do we implement, and then how do we maintain and optimize, right? So it was very easy for the two of us to be able to kind of communicate in like terms. And the output from this initial work was that we had workflow diagrams and functional requirements that I was able to hand over to Jason when it came time to build.
Thank you, Chris. Okay. As the IT project manager responsible for bringing the staff assignment application to life, my first task was to understand which tools clinical staff use to assign nurses to patients. A dry erase whiteboard here served as the centerpiece. Presented here is an example of the staff assignment unit whiteboard for the 2A cardiac unit. What I discovered as an IT guy is that nurses are very, very resourceful. For example, to identify and assign specialists, they use color-coded magnets. In another example, particular nurses were identified of a particular color. You can kind of see this green, blue, red. So each nurse had its own unique color. To fit these numerous markers, there were cups for storage, one of which states, "Do not remove these markers from the board." To reduce repeated writing or writing that would rarely change, magnets with printed labels were used right here and here and here. You can easily witness that room, patient, doctor, nurse association there and over there. And this allows for quick reference amidst a busy day. There are also some customizations present on the right side. Clinical staff allocated space for noting rooms for maintenance, buddy RN assignments, and the upcoming procedure docket. As concise as the surface area of this dry erase whiteboard is by far the lifeblood of Valley's nursing operations. It was my task to transmute this dry erase board through digitization into some other sort of application that could be used digitally. Here is a snapshot of our planned systems and their integrations. This represents Valley Health System's vision of a connected hospital incorporating multiple applications, what we call the best in breed for our new facility. Each of those lines there, every little line there, represents an actual or abstract transmission of information between independent applications. Notice that purple box with the question mark? There. This is where our new staff assignment application needed to fit amongst all these other applications and busyness. It had quite a heavy lift, and many other systems depended on this little purple question mark to properly realize our vision of a connected hospital. So what was our next staff assignment application from a technical perspective? Our general approach was we had to start somewhere, and that first step was to capture all the nuances of all assignment processes of our clinical staff. This took great coordination with Chris, but I think as Dr. Lambert mentioned in our previous presentation, it took some participant observation. I had to go in and watch what nurses did and ask them questions. As representative of the Information Systems Department, I outlined the technical limitations and requirements within our planned IT infrastructure. I knew this would take several conversations, thus we scheduled an iterative series of meetings. If there is advice to be offered to anybody who wishes to undergo the same task, it is this: do not presume that this sort of collaborative effort will succeed in only one step. And our major research effort was to clearly define the functional requirements of all staff assignment processes across all inpatient units. So we called together a summit. How do we bring this approach to bear? Well, simple. And let me read this right. We convened a gathering of esteemed, illustrious, and genteel colleagues from clinical, nursing informatics, and information systems and put them calmly, peacefully in a room together. The lofty goal: identify feasible options for Valley's next staff assignment application. To facilitate this discussion, we established some ground rules, such as please be as detailed and precise as possible. That one directive led to numerous in-the-weeds conversations that reaped significant details about our multifactorial staff assignment processes. These discussions were also, admittedly, sometimes contentious. For example, sometimes people found themselves advocating for systems they had strong familiarity with, or systems that served a business need rather than a functional need. The latter of which was a reason for convening this type of summit. When these types of flare-ups occurred, it was good to have a moderator to refocus our independent groups into one goal. In the end, we narrowed down our staff assignment application to 3 candidates and/or possibilities. The first option was our EMR Meditech. Now, I would like to add a disclaimer before further conversation. With all the changes and additions of systems to the new hospital, the Information Systems Department retained 2 critical technologies: our EMR Meditech and our communication system, Vocera Edge. As such, we evaluated these extant systems first. It became immediately apparent that Meditech would not be able to suit our needs. For instance, Meditech can only assign physicians to patients, not other clinical staff, such as RNs, charges, etc. Assignments for these nurses were really just display filters for patient lists. Second, and this was kind of the deal breaker, Meditech does not have the native capability to send assignment data to other systems. Remember that spaghetti diagram from earlier? So many systems depend on this data from the assignment tool, and Meditech's limitation quickly disqualified it. We did ask Meditech if they could develop something for us by opening day, and they admittedly could not. So we had to look at other options. Option 2, which is also a native technology, was Vocera. It was our communication system, still is our communication system. It was previously called Patient Touch. So what's Vocera Edge? In terms of my technologically centric brain, it's an iPhone customized for a clinical setting. Chris showed a little bit of it earlier. An app installed on that iPhone permits communication between the owner, a nurse, and the Vocera server. Most clinical staff have one on hand during shifts. Nurses can perform staff assignments for themselves or others at any time. Here's a real-life metaphor. I have a 5-year-old at home waiting for me. Imagine if you are his kindergarten teacher and 20 kids like him are trying to say something all at once. That is Vocera Edge assignment. That kind of cacophony threatens our notion of having one place, one source where assignments occur. In addition, given that multiple downstream systems rely upon this up-to-date and accurate assignment information, Vocera's asynchronous assignment methodology made it very likely possibility of information collision, or in other words, whose assignment is correct. So this reinforced our mission to define a source of truth staff assignment application that brings Chris and I here today. Our final option was Connexall's newly developed whiteboard. As mentioned in that first bullet, the fact that it was novel also helped us to customize it to a good extent, a notion that Connexall helped us to realize through working with us. We are also fortunate that we had contracted with Connexall to do our alarm management. Thus, a segue to this new effort was very easy. It looked a whole heck of a lot like those analog dry erase boards you saw before. So adoption was quick. It was a centralized assignment engine, and so it was browser-based with a centralized server. This allowed for multi-user access, but yet also secured against information collision. It has a built-in HL7 publisher to package and send data to other systems. It also permits for unit-wide roles such as physical therapists and social workers. Thus, it has broad implications for assigning personnel across the entire unit. Finally, we were able to build validation to the solution for proper assignment of certain roles. For example, only specified employees could assign themselves or be assigned by other resident nurses. For this reason, we selected Connexall as provider of our next staff assignment application. So just some quick technical considerations. I had to evaluate the outbound system traffic to these different systems. Our EMR is Meditech. Our communications messaging is Vocera Edge. Physiological monitors are Nihon Kohden. Nurse call was done by Westcom. Our TLS system was done by Centrac. And eVideon serves as the patient experience application. All these received outbound traffic from the whiteboard. Each of these had unique demands for the HL7 they adjusted, so minor changes in our interface engine were necessary. However, with a well-designed testing protocol, we were able to quickly get these systems online. Next consideration also is given the schedule, there are only so many technical resources I can leverage before opening day. I consulted with Chris, and we also tried to divvy up the day 1 versus the day 2 projects. Just couldn't all be done given our bing-bang approach to opening this hospital. My advice to other IT project managers is to closely collaborate with clinical counterparts at all times. Very important. It was also important to have a robust testing environment. Fortunately, Connexall helped us get this up and running so that assignment traffic was ready on the day that we needed it to be. Here's a good summary slide of what I stated previously and what we ended up with. The Connexall unit and hospital whiteboards exhaust HL7 data, formatted data to our interface engine Cloverleaf, which is right in the middle there, which then distributes to other systems, so it goes out from there. And each time there's maybe a little bit of a modification to the HL7, but very minimal. These other mobile applications that are spoken of here are Algae and downstream Nihon Kohden applications. The great thing about this particular situation is that we also have the ability to expand as necessary. Chris previously showed real-life examples of application use. I just wanted to review them quickly in abstract. In the case of Vocera Edge, these assignment data are aggregated and portrayed in different ways. Vocera captures Connexall unit whiteboard data and corresponds it to various other patient visit data, right here. Behind the scenes, Connexall does even more. It couples with its alarm management solution to distribute sounds and messages to each Vocera device to the nurse that said alarm pertains to. All right. This is my PowerPoint experiment. Here's a visual example of patient A is attended to by nurse B on the unit whiteboard. The Connexall solution captures the assignment, and that assignment relationship is tightly integrated with the Connexall alarm engine so that alarms from source systems like NurseCall properly reach the Vocera Edge device of nurse B. This saved us from additional networking configurations if we had selected different alarming applications and vendors. So having Connexall be part of that whole ecosystem was a very advantageous situation for us. The unit care board for Westcom, as I mentioned, one of the vendors we have, is displayed on the wall nearby every nurse's station, and Chris will show you some real-life examples of that. It provides a quick display to staff as to the patient's location, as well as visual identifiers specific to each patient's condition, such as fall risk and food orders. The unit care board collects those assignments sent from the Connexall unit whiteboard, shown within the red border above, and posts them nearby the nurses for easy reference. eVideon is an in-room informational display customized for each patient. Here's an example. eVideon collects Connexall unit whiteboard information into a summarized My Care team, bordered in the red here. In this instance, the patient is informed as to which clinical staff is taking care of them. From here, Chris will further elaborate the holistic patient experience and overall results.
So I think Jason did a great job of explaining kind of what we did on the back end, but I always want to bring it back to what's the clinical experience. So what you see on the board behind over here is an example of the unit whiteboard. We took the leftmost section that represents about 75% of the screen, and we created it at each row represents a patient. So we have the room, the patient name, but we're assigning the primary nurse, buddy nurse, and PCA up there. What we had and worked with Connexall to do is to create this notion of the right-handed column, because we know that not all assignments are at the patient level, some of them are at the unit level. So we put in roles like nurse manager, charge, educators. What you can't see on here is that list goes down a little bit. And we actually have roles that are ancillary that are supporting the unit. So my PT, my OT, my therapist, they're all there. It's all under this really simple and easy to use interface, and like we said, trying to mimic those analog boards that nurses have been using for years. But what's hidden behind this really simple interface is a lot of business logic. And we really did this to be able to kind of put guardrails on how things operate. So when I go to assign a primary RN, what the nurses don't see is that it's automatically taking a search at our Active Directory and saying, who has the credentials of being an RN? For usability, it's only going to show those nurses that are available in that unit, but also it's going to prevent assigning a PCA in the RN role. And this was critical for us because we didn't want an emergent alert to go to the wrong person with the expectation that, oh, I saw a name up there, but I went through it too quickly. Right? So we guarantee that the right people are in the right roles. Likewise, on that right-hand column, we have roles that are view only. So if I'm the charge nurse for a unit, I can see the respiratory therapist who's assigned to my unit, but I'm not making those changes. We allow them to make changes in a different board. So speaking of a different board, there's also a hospital view. And so instead of looking at things at a per patient level, like it's relevant on a unit, we know that their workflows are different. So that respiratory therapist, I'm on first floor, second floor, third floor, I'm assigning myself to those units. It's by the unit level, right? So it works a lot for those supporting services. And again, all feeds back into these boards. What I also want to highlight is underneath the users that we have over here, you'll see a time, active until 6 p.m. That was a really big win for us. So in the past, like I said, we had rules in Vocera of exclusivity. We tried to be able to get rid of stale data. By having the ability to, when assignments are made, have a start and stop time, we're able to do a couple of things. The first is we get rid of old stale data. At the end of the assignment, we log people out. They're no longer part of those care teams. They disappear off of the boards at all of the stations and in the patient room, and they're replaced with the oncoming new staff that's assigned for that. It also allows us to ask the nurses to make the charge nurse to make the assignment in advance. So the night shift charge nurse will make assignments for the day shift. So this way, when the day shift comes in, they're already displayed on this board, even though it's still during the night shift. They're grayed out because we know that they're going to start at 7 a.m. So it gives a real quick visibility to what the current assignment is, who the oncoming team is going to be and take report, and then also to automatically kind of handle that sort of transition. So what does that actually mean for the nurse? So on the left over here, we have our toasters. Any of you that use ground control will be familiar with them. Our nurses come in, they check out a mobile device. When they log into Vocera, they're already pre-assigned to all of their patients. So that's already handled. They're just taking a look, they're verifying and they're validating. They're no longer going through the step of making all of those clicks and those button presses. On the unit care board, so on the left is a picture of our nursing station. We've got one of these at each end of the units. And on either side of it, there's this board that Jason shows all of this information, and it's consolidating data from multiple places, our EMR from Connexall, and it's all putting it right there so you can see exactly who's taking care of which patient, as well as the telephone number for the Vocera so the doctors can contact them very easily. It makes it all that data in one place, and it's all updated in real time. We also talked about that patient experience. So for the care team, in each room we have a 75-inch TV for each patient. So on that TV, when they're watching it, when staff walk in, the RTLS knows that it's a clinician. It's going to pause TV and bring up this digital whiteboard, and this is replacing those old school grease boards that were in the patient room. And so now all of a sudden it's showing the leftmost column, and there's an associated iPad that the patient has as well, and it's going to populate that with the name, the telephone number for their mobile extension, as well as a photo of the staff. So this way the patient and the family really can put a face to name and understand who their care team is. So we build all of this, and we're building it actively as we're building a new hospital, and I'm probably going to date myself here with a picture of the cornfields, and if you build it, they will come. But to Ed's point yesterday, it's not just technology. We have to look at things with the eye of empathy and really understand what the impact is. So I've got a short little video that I want to be able to showcase here.
Let us know. Okay?
Thank you so much.
They're going to come in for your vitals.
Thank you for everything, folks.
Our first patient from Ridgewood is getting close.
Thank you so much, ladies, for the ride.
Oh, your pleasure.
Again, it's about patient care. So all of the technology that we put together, all of the integration, all of the whiteboard, it's all to allow clinical staff to do their best and to be able to take care of the patients. So our go live. So the question that I ask everybody is, what do we expect to happen when we have to transfer over 200 patients from our existing facility to our new facility? When I have hundreds of brand new clinical staff that are descending on a building they've never worked a day in, and we have all of these new technologies. And what I can proudly say is surprisingly very little. A testament to the amount of effort and energy that was put in for testing, training, and educating. On the surface, for the patient experience and for the clinicians, things seemed calm another day in the hospital. Behind the scenes, it was hectic. Right? I think we can all acknowledge it. We've all been there. We had ICS stood up in both facilities, and across from that, we had in our largest conference room a massive command center. We had our entire IS team there, basically, as well as informatics, and we had representatives from each of our vendors for the technologies that were in place. And we staffed this 24/7. So from the Elevate team, before they had that really cool name, we had a bunch of Connexall staff sitting there, right there at the desk alongside of us, be able to kind of troubleshoot in real time. Again, we turned it from addition into calculus by changing so many variables. We really wanted to have the ability to get the right people at the table at the right time to be able to troubleshoot this. And what we found out was there was emergent training requirements. We had relied on nurses, and when we asked management, who's going to use these tools? And here's the list, and we provided training in advance, and here are the teams meetings. And then all of a sudden when we go live, this person needs to use this tool as well. So does this person. So there was very much a demand and ask of basically getting out there and essentially providing that training so that these people could use the tool, because this tool is now so important as it affected so many downstream systems. So we had support tickets, we had all the sort of things that were going on. We're identifying basically day 2 areas for improvement. We were forced into a rapid adoption. Again, the system needed to be used, and the system was used. But we also found that our integration was pretty seamless. The staff picked it up and kind of ran with it. By having kept the board simple and so like the existing whiteboards that we had, it made it really easy to adopt, and really became technology that was helping enable them rather than working against them. They started finding little features that we had that we built that we weren't even really publishing, that they said, hey, this is a really nice thing to have. The ability to click a button and see the historical assignments from the past for those units. They historically had pieces of paper and grids they were scanning in and sending down to the resource center, right? So now it's all digital, it's in a database. They have visibility across units. They can actually say, hey, my patient's transferring up to that unit, who's gonna be the nurse taking care of it? Again, we had different boards based on how the clinicians had to use them, right? The unit whiteboard versus the hospital whiteboard. And then our IT team did a really good job of breaking down barriers. So things like putting the entire environment behind load balancers, simple URLs, putting links everywhere. We really made it easy for the staff to get to the tool. But how do we measure it with numbers? So again, earlier we said it took about 15 minutes for each staff member to make those assignments. Well, what we found is we kind of consolidated that down to 15 minutes for one staff member to make that assignment. Because now the charge nurse was making that assignment or delegating it to your unit clerk, and it was done once per shift, plus maybe as the additions came up onto the unit. So we do the math on this again, and it's now a half hour per unit instead of the 5 hours. We're saving 4.5 hours per unit of clinical time that we're able to give back to the nurses and staff, that they can go back to doing things like patient care. Across the hospital, that adds up to almost 70 hours a day of additional clinical time that we're gaining. The other aspect was accuracy. So when we audited post-implementation, we found that the accuracy rose from about 75% correct staff assignments to 95% correct staff assignments. It's so easy now to do the assignments and to do block assignments that it's just a no-brainer. And because it's in front of the nurses, everywhere they turn, whether it's in the patient room on the board or directly across the screen, they can easily see if there's an error or mistake. So it's a little bit of room to grow over there, but very happy to see those numbers. A little bit about the summary. So I guess when you ask, did we accomplish what we set out to with this project? And we did. We have a utilization now of this unit whiteboard. It's centralized and standardized assignments, and it goes across a variety of systems. We put a lot of business logic in to kind of really have that workflow exist behind the scenes, so the staff nurses don't have to know about the workflow. We kind of take care of that for them. It's just easy to use. It's improved efficiency, reducing the amount of time spent doing those assignments by about 90%. And importantly to me, is that it increased staff satisfaction and patient satisfaction. Patients love seeing the pictures and names of their care team on their iPad or on the TV. But the staff love the fact that the technology is actually working for them this time rather than working against them. So for the future, there's always plans. Like I said, this was a day 1 implementation. This went live in April. So we're still kind of making improvements. Things technical like accelerating rendering times, but also a lot more workflow and a lot more addition to this unit whiteboard because it's become such a key technology that we're doing. And I kind of want to take a little bit of time to share some of the learnings that we had while going through this. The first is the big bang, it's a big headache. Everybody has their approach to it. Operationally, it may have made sense in order to basically shut down one facility to be able to move everybody over and not have to have 2 hospitals stood up. But what we ended up doing from a technical side was we were consolidating all of those resources that you would use in a phased approach, and we were condensing it all down. We ran a 24/7 command center for 7 days, and we were busy the majority of that time. And that was just a required evil to be able to kind of have that sort of rapid response to all of these changes that were there. So although I would say it's absolutely doable and we were successful in accomplishing it, it may not be something that I recommend to folks. The next was a mock-up space. So if any of you guys have ever done construction work on your own home or had the privilege of opening up a new hospital or new tower, you know that construction does not follow the deadlines that they set. We had an initial overrun, and we basically said, okay, we're going to push back our go-live date. The second go-live date was there. We were still overrunning, but guess what? There was a marketing push. There was press. There was everything out there. It wasn't an option for us to push again. So the amount of months that we had to do the integration initially got whittled down to weeks. So by having an actual facility literally across the street that was an offsite that stood up a full test environment, we were able to at least make progress and really kind of have everything mocked up in our test environment before going live, and that's probably one of the only reasons we were able to go live successfully. Defining the target audience and level of use, and I kind of alluded to this earlier, we had initially 200 users defined as the target users for this tool. By the time the dust settled again, it was 600 users. So how do we get to those 400 users and all of a sudden train them because they weren't part of the initial team's training? So we put together things working with Connexall. They actually did our clinical sports specialist recorded an entire education video, and we put that up on our intranet. We had that as a resource. We had follow-up on-demand and ad hoc sessions, being able to educate these users. And ultimately, because they were on site with us as a partner, it really allowed us to get to the nurses, to go upstairs to the nurses station and basically do elbow side support and really get these users brought up to speed quickly on how to use the tool. And again, the education was critical. Some of the other challenge, though, that we saw was that we really wanted to have a standards compliant solution, and we chose that we were going to use HL7 publishing for our staff assignments because it really set the bar to say, in the future assignments, we know that we're going to want to have any new application say, we're going to give you the HL7 staff assignment. It's on you to have a client to be able to read that and input that. And we're doing that with some of our applications vendors, like our AI fall prevention, saying, hey, you guys need to listen to this assignment so that we don't have to duplicate it. But for those that have used HL7, there's limitations there as well. So although it's standards compliant, HL7 is patient-based. So how do I handle the workflows of things like empty rooms? Right? So I may have staff assigned to an empty room, but I don't have a patient there. There's a lot of workflows and workarounds with queuing things and trying to figure out how to send stuff that we kind of had to work through. So it really worked as a double-edged sword. And to that next point, tool flexibility is important. I think this is one of those areas that we're still working with Connexall on kind of that next iteration. So our hospital, like I said, we actually downsized when we moved. When it was being designed, this was pre-COVID, and the assumption was more things will be done outpatient, in physicians' offices or in outpatient centers. So we actually went from having 425 rooms down to 370. And it turned out that it was a mistake, right? On day one, the census was already over, our capacity. So it was really requiring our entire hospital leadership to say, how are we going to tackle this? How are we going to handle this? And through a lot of creative flexing and taking space and saying, we're going to convert this area from a subsection of the ED to now an admission unit. We're going to take this area in diagnostic imaging and use this for holds, and we're going to, dare I say it, put a hallway bed or have 1 or 2 non-private rooms. We added capacity. So as I said, we're about like 416 right now. We're still bursting at the seams. But one of the things that we implemented was the idea of flexing rooms. So on some of our units, that room may be part of step down, and then the next day it may be part of med surg, or in this case we have adult units flexing to pediatric depending on what the census is, so we can react and respond to it. We need tools that are able to react and respond in kind. And so right now, although we have the ability to flex with things, we really want to kind of push that more into kind of a self-service model so we don't have to be calling up Connexall and working with them every time we kind of have to make these swings to be able to kind of handle this patient load. So really, flexibility is pretty important for us as well. And I think that, as a nutshell, that's pretty much the learnings that we had, which were, it was really important to have clinical and IS attached at the hip to be able to have successfully launched this. It was really important to have a really good test environment. It's something that we kind of had to fight for. I know a lot of people here ask for that test environment, and you hit some resistance. Nobody wants to spend money, but it was really what allowed us to be able to go live with that big bang solution on the day that we went there. And then it really was that partnership of working with Connexall to be able to have those resources available to help us for not only the programming and the go live, but also that emergent support need that we had when we went live and had to figure out how do we get 400 additional users trained in the span of a week. So I think that that's kind of the gist of our presentation. I invite Jason back up here, and we're happy to answer questions that you guys might have about either our experience, the staff assignment tool that we kind of worked together to build, or any of the technologies that we integrated with it.
Hey, James Wilson with Scripps Health. I'm super impressed by what you guys pulled off there. Very encouraging to see somebody making the progress you guys have made. I'm curious, there's a whole lot now that you have touching that purple box in the middle. Mm-hmm. Did you do anything over and above to really ensure that that system stays up and running? What sort of considerations did you take for BCDR, and did you come up with additional downtime procedures now?
I don't know if you want to talk about general downtime procedures for technology, but I'll talk about the purple box after he goes.
Yeah, so one of the things that we did was with our push to Vocera, we actually locked those roles down, and we basically said these roles can no longer be assigned on devices. It removed that, classroom full of kindergartners effect of having a lot of sources there. But we have the ability to roll back on that. So if the Connexall system, for whatever reason, went down catastrophically, users can still pick up that Vocera and use that old method of being able to make those assignments, so that there is some element of kind of continuity there that isn't dependent on a single sole system that's there.
Right, I can tell you about in terms of securing it to make sure that it doesn't go down. We have a primary, we have a secondary for each of our different applications, 2 for the web client, 2 for the actual CNS, and then 2 for the other applications. So we have actually 6 servers stood up spinning. So anytime there's a failover, it'll automatically go to the secondary, and then we also get notices through email about, by the way, primary is down. Can you do something about it? I don't know. It's kind of a general IT policy or guideline to always have a secondary system, and we made sure that we have that for all of the things we use for Connexall.
So you'll still fall back to the whiteboards.
Correct. Yeah. Always synced too. Always synced.
Hey, Steve Landry, Scripps Health. Great presentation, guys. Enjoyed talking to you guys last night.
Absolutely.
My question to you is, who's responsible for making the assignments? Do the oncoming set the offgoing, or offgoing set the oncoming? And also, once the assignments are made, how are you guys validating that they are logging into the Volt application to receive the alerts?
Sure. So our policy is that we kind of have the charge nurse from the shift before make those assignments. The idea behind it is that once the staff come on board, it's already preset in the system, and because we have time-based assignments, that's how it works for us. As far as making sure that the user is logged in, it's still actually an active area of development for us. So currently it requires the charge nurse to actually log into Vocera on a desktop application and take a look at the assignments for the unit and see basically the status symbols that are there for their staff. So the goal there is to automate that in and be able to actually use those color coding that's there. So because we use Vocera Edge, we don't kind of have the benefit that you would have if we actually used Mobile Connects, where it kind of communicates back that assignment automatically. So we're kind of recreating the wheel by doing that bridge and that integration.
That's one of our biggest struggles right now.
Oh, yeah.
Question here. So we talked to you a little bit last night. We're also a Meditech user. So the question I had, on our Meditech, we go through semi-periodical downtimes for Meditech. Question 1 is, how does that affect your whiteboard, and if you guys have to go through those downtimes as well?
It doesn't. So Yeah, it's a Meditechism. We know that downtime is there. Meditech acts as a receiver, so it's a downstream system from the staff assignment. So what actually we have in Meditech is that they built something for us where they listen into that HL7 staff assignment, and they pre-populate the nurse's list of patients based on what we send them. So we are not necessarily asking them for anything, so it doesn't impact the other downstream systems. So really they're acting as a recipient. Where it might impact things are our nurse call systems that kind of had those big unit care boards that pull patient indicators and flags, right? So that is done kind of using ADT, and a lot of times they're singular, so we'll pull that information, and as long as that information has changed during downtime, it's still going to display. We may not get up-to-the-date changes in those status indicators that normally would reflect it. But for assignment purposes, Meditech's downtime, or any of the downstream systems for that matter, don't impact the other systems.
All right, perfect. Thank you. Great job.
Quick question. So, speaking of ADT, where are you guys getting your feed from? How does that, how with the system for transfers, downtime, stuff like that, how robust is it in handling those patient movements?
Patient movements.
So, it's a loaded question.
Yeah.
So, as far as patient assignment to a location, that's obviously coming from the ADT, I want to say it's ADT 08 feed that we're getting from Meditech. So that's basically, we're able to kind of take that, parse that, and then basically look things up. So to the point, if Meditech is down, new patient admissions, there's going to be delay on that. Existing assignments, not so much so. All of that kind of comes through our interface engine, and our interface team basically kind of does transformations and changes to give us the data that we need to have this unit whiteboard work with it.
Yeah, it was kind of that hub that in the center, like the little thing I showed. It's Cloverleaf is our interface engine.
So then, like if you have a patient transfer, right? So let's say they're going from one unit to another unit. Are you are you waiting for that transfer to happen and come over, and then they're going to add the new nurse once they get to the receiving unit, or how is that workflow working?
Yeah, so what we're doing is we're ultimately going back to kind of a grid model for anybody who is clinical, where we're basically attaching the nurse to the unit rather than the nurse to the patient. So what happens is, in this case, we have a patient coming up to the second floor. If there's already pre-assigned a nurse for that room, the minute that patient is now attached to that room and we essentially map those up, that nurse is now the nurse for the patient. If that patient comes up and they're in a room that doesn't have a nurse assigned, the charge nurse will literally have the unit whiteboard that we showed. They'll see it, they'll click, and they'll basically assign the nurse to it. Again, at that point, that assignment is made. But because we're assigning that nurse to the location, the nurse doesn't follow the patient. It's rather the nurse on the receiving unit who has that room is going to have that patient.
Right. Yep.
Chris, you just answered my question. So, thank
Hopefully
you.
right. Hopefully it's a good answer.
Yeah, well, no, I'm sorry. Candace Freestad of Air Health. I wanted to know if you could assign for room and for patient. You could do one or the other.
So, not to steal thunder of, what future development may be, but that is
yeah,
actually...
no, I am not a plant, just so you know.
Yeah, that is an ask. So
yes.
in the model as a whole, what we found was location-based assignments work actually really well for inpatient because patients are going to be there for a while. A lot harder to do for areas like the ED or procedural areas because the turnover is so quick, and there's just complications in that. Additionally, some of our systems, we actually kind of really had to rig. So one of them, I'll say, is our physiologic monitor. It didn't have the capacity to send a room number. It just wanted to send the patient's V number, and we basically had to sit there and say, how do we work with this? So we had to really come up with a way of being able to match those alerts and those alarms to a location, because Connexall keys off of location, so that's how we kind of brought it all back. We've asked that one of these things we look at is how do we kind of create that dynamic mapping also to patients. So not only is it location-based, but also can be patient-centric.
Right. One of our asks.
Okay.
Well, thank you very much.
Thank you guys very much.